Good morning, everybody. Welcome to today's Insight APSAD webinar. I'd just like to acknowledge the traditional owners of the land on which we live and pay respects to elders past, present and emerging. So it's our pleasure today to introduce Professor Paul Haber with his presentation around the current guidelines for treating alcohol problems. If you have any questions along the way, please press the chat button. Yeah, I'll pass it over to you, Paul. Thanks.
Thank you very much. So welcome everyone, and I would also like to begin by acknowledging our Aboriginal people, and I come from Sydney. I'm speaking in Sydney now, so I'm on the Gadigal land of the Eora Nation and pay my respects to Aboriginal people past and present and any in the audience at the moment. Now, excellent. Okay, so what I'm going to talk about today is the guidelines for treatment of alcohol problems. That's a project that I'm working on with a team of colleagues, and it's not finalised, and yet we've made a lot of progress, so I'll tell you where we're up to. And also it is still open for feedback, and we would welcome that both in this presentation and perhaps by email or telephone afterwards. So I want to start with some description of the key points of epidemiology about alcohol use that are contemporary and that inform our treatment approaches in 2020. So it's interesting, many of you will be familiar with the fact that per capita alcohol consumption in Australia is now at the lowest point for 50 years. And whilst that is pleasing, the points I would make are, firstly, that the consumption level has come down in the last few years, but it actually went up in the few years before. So although it's lower than it was about 10 or 15 years ago, it's actually only very slightly lower. There has been a historic shift from beer, which was in the 70s, was by far our dominant drink, to now basically where beer and wine are almost equal in their popularity in Australia. And what we've also seen, interestingly, is a historic rise in spirits. And in the United States, there's actually a glut of wine because young people are drinking spirits rather than wine. So I think the past generation had one shift in their tastes, and we're in the middle perhaps of a second shift in preferences. Not shown on this slide is the consumption of cider, and that's been rising in the last decade, but still remains rather low, just a couple of percent. Well, yeah, a couple of percent of the total. So the next piece of interesting information is that heavy drinking of alcohol in young people has actually declined over the last sort of 5 to so years. And there's lots of other metrics that back this up. But what we've seen is actually an increase in older drinkers. So is this because older drinkers are actually increasing, or is this a cohort effect, such as people of that generation are continuing to do what they always did, but people of the younger generation are just not drinking as much? And I think it's probably more of a cohort effect. So we're not seeing an individual on average drinking more, but rather that whole generation is just persisting with what they used to do. And perhaps that augurs well for alcohol problems in the years to come, but it kind of also suggests that older people who present different clinical challenges are going to be a larger caseload compared perhaps, or relatively speaking, a larger caseload than the younger people. Now that trend aside, it's also fair to say that we're still seeing the age-old trend that overall young people drink more than older people. It's just the relative changes within that overall effect. Now, this is American data but it's highly topical. It just came out last week. And what it's shown is that in the United States, the mortality associated with alcohol problems has actually gone up quite significantly. You can see this is data over about a 15-year period, and you're looking at changes of upwards of sort of 25%. There's a dramatic difference between men and women here. The difference in Australia is not as great. Particular risk groups in America were men, as I've just said, non-Latino white, so quite substantial differences between cultural groups. And here we see a state-by-state map, and that indicates that there's a dramatic difference between what's basically the West Coast, where the alcohol-related mortality is 2 or even 3 times higher than in the centre of the country, and more or less like the West Coast in some parts of the East Coast. But a very striking difference, as much as a 5-fold variation between the lowest and the highest states of the USA. And we see something like that with higher rates of alcohol problems in the Northern Territory in Australia. So we have the patterns that are really affecting alcohol use in Australia. Men are drinking more, but there seems to be a greater use of alcohol relatively by women, so the gender difference is declining, and men are reducing their drinking more so than women. Younger adults, significant decline. The other thing I wanted to highlight is that LGBTQI people are likely to drink more than their peers. Aboriginal Torres Strait Islanders are more likely to abstain, but also more likely to drink in a high-risk fashion if they do drink. And the regional differences I've just mentioned, but rural areas in Australia, particularly more drinking, more risky drinking and more alcohol-related harms. So these 3 cultural groups are particularly important when it comes to the treatment of alcohol problems, not only because they're at high risk, but because there are particular challenges in managing them. We have more abstinent people in Australia compared to 20 years ago, fewer daily drinkers, more people who drink infrequently, so unlikely to be of much harm, and fewer who exceed the lifetime guidelines. So that kind of says that we're dichotomizing our alcohol consumption as a society, with a majority who are kind of drinking a little bit less, but a minority who are drinking as much as they ever did and maybe more. Consequently, it is not surprising, I think, that alcohol-related harms in our country are not falling. We had almost 6,000 deaths in 2015, and the number of deaths is stable over 15 years. It comprises 8.4% of death in men and 2.2% in women, 4.6% of the total burden of disease, and almost 150,000 alcohol-related hospitalisations, which is a lot. What's that? 500 per day. I'll just say that again. 500 people admitted to hospital for alcohol-related problems every day in Australia. Hospitalisation trends increased in the early 20s and then stabilised in the current decade or decade just past. So it's probably not going up further, but it's not really going down either. This study is identified that when ranking alcohol against other drugs in terms of overall harms, alcohol is far and away the most harmful drug in Australia. And the particular reason for this is strikingly harm to others, which is the red bar, compared to the blue bar, which is harm to the users themselves. And of course, we know that alcohol is related to all kinds of harm to others, and that's a critical aspect. And the implications for that are that when we treat a patient, the person that benefits might well be a member of their family or a member of the community more so even than the individual we're trying to treat. And consequently, if we reduce someone's consumption, let's just say from 20 drinks a day down to 8 drinks a day, that person may still be at high risk of health problems, but that lower level of consumption is much less likely to cause harm to other members of the community. And consequently, there may be a very significant treatment benefit in that example, even if it's not met any of the endpoints for successful treatment. I want to give you a little bit of background now of our guidelines project. So there have been previous guidelines. The currently online guidelines are the 3rd edition, and I edited those as well, but that dates from 2009, which means that the research work was done in 2007 and 2008, which makes the content fully 12 or even 13 years old, very out of date. One of the other challenges with that guideline was that there was a really limited dissemination strategy. We printed copies of them and we posted them as a single PDF file on the Commonwealth Health website, but there was no publicity associated with it. There were no training materials. There was no dedicated website, and very little awareness of those guidelines ever being released. I just want to highlight that the focus of what I'm talking about today and what our project involves is the guidelines on the treatment for alcohol problems. It's not on prevention strategies, and it's not on consumption advice for the general community. I'll make some reference to these things because, of course, there are relationships, but they are outside the scope of the project that I'm going to be talking about. Now, NHMRC has literally guidelines for guidelines. So there's a process for having clinical guidelines approved by the NHMRC if they are produced by methodology that meets the NHMRC criteria. Now, unfortunately, we are not able to meet all the criteria, although we're meeting most, and we've made every effort to do so. But the key issue for us is that one of the NHMRC criteria is that you perform a systematic review for every recommendation that you make. Now, in treatment of alcohol problems, as you know, alcohol problems are pervasive across the whole of human health, and consequently, we make over 150 recommendations in this broad document, and it's not feasible to do 150 comprehensive, systematic literature reviews. And so we will not meet NHMRC criteria formally, but we are doing our guideline project consistent with NHMRC principles, and we'll meet most of the other requirements. So this guideline development process tells you what we've been doing. You will notice that the timeline is finished at the end of 2019, and that means we should be finished, and we're not. So we are, like many others, running a little behind schedule. But you can see that there are multiple steps in this process that involves ensuring that we are asking the right clinical questions, that we are giving a broad range of people an opportunity to provide comment, and that the full guidelines have an opportunity for community consultation, and that the results of that consultation are taken into account when the document is finalised. And we will be releasing our document for community consultation probably within a month, and I very much invite all of you to take a look at it when they're released. It'll be released online, obviously, and your comments will be welcomed, and we might even listen to them. Who can say? So we did some surveys about stakeholder engagement, and to identify barriers, facilitators to dissemination of the guidelines, we looked and we identified areas that were of great interest, like ensuring that we had more content around the issues of stigma and on models of treatment, models of care. Barriers to implementation of guidelines involve time, access to information, training, easy to find website, and it was felt that the best way to disseminate it was through the professional societies and training, such as this, what we're doing right now. But others felt that the website is very useful, but you still have to print it. You know, people still want to have paper in front of them when they want to look at it. And obviously that means we're paying for websites and we're paying for printing, which is lovely, but it's expensive. Our stakeholder survey involved 250 practitioners from across Australia, and I hope that does include some of you from Queensland. We asked our stakeholders, how often do you see a patient with a drinking problem? And the most common response was daily, and really daily or several times a week. And it's only this white section that would say less than once a week. So we had 250 people that see patients with alcohol problems often. However, 75% had not seen the 2009 guidelines. So 75% had not seen the 2009 guidelines, which I think is very disappointing, but it does reflect the fact that firstly, they're very old, and secondly, they were not disseminated properly. Other barriers to the use of guidelines were identified, as well as facilitators, things that the people we consulted thought would encourage guideline utilisation. This looked at what content people wanted to see, and I'm surprised this isn't projecting. Can you see here, if I just look at the slide in this view, you can see it, but when I project it, then half the content disappears. I don't understand Microsoft products all the time. But what we can see here is that people were very keen to know about withdrawal management, screening and pharmacotherapies, and increasingly less worried about some of the other issues. And they were very uninterested in some of these chapters about introduction and prevalence and aftercare. So we want to make sure that we focus on the topics that are of greater interest, and we'll be doing that. So the first point we wanted to make about the new treatment guidelines was that we had to fit in with the new NHMRC consumption guidelines. And I hope most of you are aware of these, although they were carefully released 2 days before Christmas just passed. And I think they've had a very low level of public consultation. But here they are. They've honed down the guidelines to just 3, and they are guidelines for healthy men and women. They're guidelines for children and young people, and for pregnancy and breastfeeding. And basically, the guidelines are more stringent than ever before. The recommendation for adult men and women: drink no more than 10 standard drinks per week, no more than 4 standard drinks on any one day. The 10 is a new number, and it's down from what was previously 2 drinks per day, which is 14 drinks in a week. So it's gone down from 14 to 10. And the no more than 4 is unchanged from previously. Children and young people should not drink alcohol, and that is more stringent than previously. Women who are pregnant or planning pregnancy should not drink alcohol, and for women who are breastfeeding, also they should not drink alcohol, or it's phrased slightly differently. And so they're kind of saying for groups 2 and 3, you shouldn't drink alcohol at all, and for group 1, you should only drink that amount of 10 standard drinks per week. So although these are still in draft, it would seem very unlikely that the finished product will be different from what we're looking at on the screen at the moment. They'll probably release that in August of this year. And there will be some publicity and some public marketing around those. So our treatment guidelines have to fit in with that. Now, our basic paradigm for our patient flow in assessment is shown here, and this is actually from the previous guidelines and will not be changing. First, we have to make some screening, and if the patient is drinking within low risk levels, we can encourage them that they are in fact drinking within low risk levels. If they're drinking in excess of that, we may offer them a brief advice or other brief intervention to encourage them to reduce their drinking. If they are effective in doing so, we can, at follow-up, congratulate them and carry on. If they have more moderate to severe problems or dependence, or if they are unable to reduce their drinking in response to a brief intervention, then it's recommended a more comprehensive assessment and more comprehensive treatment intervention is offered. That's going to be the same. And basically the subject of the rest of this talk is what comes into that last blue box there. Now, my first observation is that we've got a little bit of a problem with the new consumption guidelines in that there is no structured instruments or interventions developed to address what is, of course, a new guideline. So if you look at the AUDIT-C, which is a standard screening tool for recognition of excess drinking, I've put in a black box this question 2, this item here that says how many standard drinks do you have on a typical day? It says 1 or 2. Well, 2, if you drank typically, would bring you in excess of the new consumption guidelines. 1 would not. So the difference between 1 or 2 is not being picked up by the AUDIT-C at all. Consequently, our recommendation here is that quantity frequency estimates are recommended to detect levels of consumption in excess of guidelines. And so the role of AUDIT-C will be to detect higher levels of alcohol use, more in the range of alcohol problem consumption problems rather than drinking in excess of current guidelines. So unfortunately, whilst we have a solution here, the solution raises a new problem. Does anyone want to comment about that? Is this an okay time for us to stop briefly?
Do you have any suggestions as to how you would get the estimate in a 3-question guideline?
Well, it would involve changing the AUDIT-C, and the problem with that is that the audit questionnaire was developed by the World Health Organization in the 1990s. John Saunders may or may not be on the line at the moment, but he played a key role, and a number of Queenslanders have been involved in its development and dissemination. The AUDIT-C there are millions of copies of it. It sits on most desktops, on most computers, and we have an extensive data about the population level scores for this instrument. So sure, we can change it. You know, it's only 5 lines long. You've got a typewriter, you can change it. But then you have no community data about what the scores are like, and less ability to compare an individual with the rest of the community. So that's the problem with changing what we recommend people do. On the other hand, if we don't change what people are supposed to do, then we're not changing our recommendations in the light of new evidence about the harms of alcohol. So we're damned if we do and we're damned if we don't. I don't have a perfect answer. I'm just highlighting that we have a bit of a challenge in how we operationalise this stuff. I'm going to move on, and I thank you for asking the question. Now, STIGMA is a new chapter in the guidelines, and stakeholders have identified stigma of alcohol use disorder as a key area to cover. The chapter makes key recommendations around the use of language and how to treat the patient. Recommendations include undertaking anti-stigma training, ensuring there's peer input, using person-centred practice, refraining from making moral personal judgments, important recommendations about the use of language that can be stigmatised. I've put something in italics that clearly would be a very stigmatised description to use about patients, but we also know that it's widely still done. And organisational recommendations, not just for individual clinicians, but for our organisations, about peer workers, introduction of peer workers, ensuring we have a complaints process so that adverse incidents like this can be detected and actioned, and that there's auditing of these sorts of concerns and advocacy for policy change. So there is evidence and literature around all this sort of stuff, but unfortunately it's not like high quality level 1 evidence, but it's an evolving area compared to 10 years ago that acknowledges that alcohol use disorder is heavily stigmatised, and also that it's incredibly important. So the next new thing was about e-health. Now, e-health interventions were included in the brief interventions chapter previously, but were little more than a footnote. Now there's an extensive literature on e-health, and one would expect there to be a significant inclusion of these various e-health interventions. Cochrane review, multiple systematic reviews have been done. Bottom line, and although there's more detail, the key recommendations are that they certainly can be used. They may have a small impact on consumption, but they should not be preferred to an in-person intervention. The effect sizes that have been published are quite small. The retention in e-health interventions is incredibly low. That is, people sign on and do it, but the chance of them coming back to it is just a few %. Also, a great concern about the e-health interventions is that in nearly all cases, they have been studied as a research project, and once the research and posted on a university website or something like that, and consequently, as soon as the research study is over, they're not necessarily accessible, and certainly they're not integrated into in-person interventions in the way that you might expect. So we actually are not there when it comes to development and rollout of e-health interventions. We do include in our recommended websites, there is a few websites that describe where the interventions are, and those websites are going to are permanent. So they will be, if you like a roadmap of how to access interventions in the future. But it's still an evolving area, surprisingly. Now, I mentioned that we had more data on specific populations. LGBTQI population were not represented at all in the last guidelines, and there's still not enough research in this area. But bottom line key recommendation is to ask about sexuality with permission from the client, and to acknowledge that this is a challenge for the patients, a risk factor for alcohol use disorder, and that this population, like other specific populations, requires particular sensitivity in how they are accessing healthcare interventions. Gender-specific issues are also something we've emphasised in the new edition. We specifically focus more on domestic violence, for which there's been much more attention in recent years. The other issues, particularly for women, are safety in treatment, particularly residential treatment, and integration of substance use treatment with other health issues, particularly reproductive health, such as contraception, which is particularly important as not only that women with substance use issues are at increased risk of adverse reproductive encounters, unwanted pregnancies. I'd like to say all the chapters have got shorter, but they haven't. They've pretty well all got longer. But that's positive news in that the evidence base has increased. We have a little bit more guidance about what to do about our patients. And in particular, more evidence around brief interventions and psychosocial interventions. The bad news about brief interventions is that as the literature has matured, whilst the effectiveness remains well established, the effect size appears to be diminishing over time with research. Biomarkers. So this is a copy of some of our recommendations on biomarkers. We are recommending direct measures of alcohol in breath and or blood as useful markers of recent use and useful in the assessment of intoxication. My clinical experience is that they're often underutilised, and it's incredibly valuable when we see a patient, often in hospital the day after their admission. And I can remember many encounters with patients when I say things like, well, seems that you came to hospital intoxicated. And the patient says, well, no, I wasn't. And if I didn't see the patient when they came, but I only saw them on the second day, I'm left in a quandary. But if I'm able to say, well, the blood alcohol was measured when you were in the emergency department and the level was 106, then I'm able to provide feedback about objective measures that the patient had on presentation. Indirect biological markers such as liver function tests or carbohydrate deficient transferrin should be used as an adjunct to other screening measures, as sorry, there's some sort of flashing lights on the screen that distracting me. Should be used as adjunct to other screening measures, as they have lower sensitivity and specificity detecting at-risk populations than structured questionnaires. So this is something that people sometimes forget, which is that blood tests sound very objective and accurate, but they're actually less accurate than a simple questionnaire with the patient in most population settings. The third recommendation here is that many of the newer biological markers are very useful, but they're not covered by Medicare rebates, which means high personal cost, usually paid by the patient, or they're only available from specialist laboratories, which means that you can get them if you are at the Royal Prince Alfred Hospital, but not anywhere else. And they may be particularly useful in medical legal assessments, but they're often unobtainable in general practice. So they should be more widely available, and obviously it would be great if they were more covered by Medicare or covered by somebody, so the patient wasn't paying the cost for this test, remembering that the cost is often over $100 for a single test, which is really a lot of money. A lot of money for a blood test. Now, this is a specific study I wanted to highlight on the subject of pharmacotherapy guideline recommendations. This is a Sydney baclofen trial that was published, it's nearly 2 years ago now that it was published, and it showed a significant effect, a beneficial effect of baclofen versus placebo on time to lapse on this graph, but also in time to relapse. And with a number needed to treat based on the criterion of continuous abstinence at week 12 was 8.3 patients. So that's an effect size that is fairly similar to the effect size seen for antidepressants, blood pressure tablets and the like. So a pretty useful effect size. And that, along with other research involving baclofen, gave rise to this recommendation that we made, which is firstly to recognise that this is off-label prescribing. Off-label means literally that the registered indication for the drug is not this. But that baclofen may assist abstinence from alcohol, but its evidence remains lower than first-line medication. And whilst I just showed you one positive study, there actually have been some negative studies too. There are safety concerns with baclofen treatment, including the risk of overdose and excess sedation. Patients with a history of self-harm or unstable mood may be at risk, and it should be prescribed with caution, and it is not recommended as first-line treatment. Baclofen may be considered in specialist settings as a second-line treatment, or particularly for selected patients with contraindications to first-line treatment, such as in the case of patients with alcoholic liver disease. So although it's a recommendation for a drug that might be effective, there's a lot of caveats and limitations on it. Next area of interest is peer support programs. And really we're strengthening the recommendation for engagement with these programs. Participation in AA is effective with high-level evidence. Assertive referral practices can increase the rates of AA attendance and improve alcohol-related outcomes, including abstinence. Smart recovery may be an effective peer support alternative. That non-12-step and non-smart online peer support may help clients, and peer support groups for families are evolving, and these may also improve outcomes for family members and significant others. So we're seeing the rise of these peer support activities. We've very much strengthened recommendations around Aboriginal people. Now, in the previous set of guidelines, Aboriginal people were covered in literally a page and a half, but there was a separate whole document for Aboriginal people, which has not appeared for, I'd say, 15 years. And consequently, we have included Aboriginal people in a significantly expanded chapter, which was authored by a working group, which was themselves mainly Aboriginal people, with Kate Conograve, who, as a non-Aboriginal person with academic expertise, helping to coordinate their activities. So we've indicated here that clinicians' approach should be informed by respect for client culture. Clinicians and associated staff should seek cultural training to ensure a culturally secure approach to engaging clients and asking about alcohol and offering treatment. Recognition that recurrent relapse can cause shame, which may be increased in the presence of internalised racism. The clinician should understand and respond to alcohol dependence as a chronic relapsing condition. And the clinician and treatment services should advocate for housing and social needs for their clients which interface with their substance use needs. That we should provide flexible access of services where possible. And there are a couple more here. When acceptable to clients, non-Indigenous clinicians should work in partnership with an Aboriginal Torres Strait Islander health professional. Now, validated screening tools have been tested in Aboriginal communities, and they include AUDIT-C, quantity frequency, and the IRIS, which is a comorbidity screener that includes mental health disorder, and finally the Assist Light. So all of those measures have been used and validated in Aboriginal communities. But it's particularly important in Aboriginal communities. I might add it's important everywhere, but it's particularly important in Aboriginal communities to ask about the container type being used and whether it was full, and how alcohol was consumed and how many people it was shared with, and also irregular drinking patterns. So it would be quite common for an Aboriginal group to let us say, drink 2 slabs of beer, and the patient might say, I drank 2 slabs of beer. But when he says that, he means he and maybe half a dozen of his friends. And so whilst they might have drunk more than is recommended, it may be nowhere near the opening statement of 2 slabs of beer. Many things have actually stayed the same. These include basic measures around screening, withdrawal management, and most of the clinical interventions, the psychosocial interventions, for example. So I'd like to keep a bit of time for questions, and therefore I'll stop there.
We've got one wondering if there are any new quick screeners in development currently.
No, but I would highlight that the audit, which was has been the most heavily used, has 10 questions. I can see on my fingers. The AUDIT-C has dropped that down to 3. But the audit question 2 or the audit question 3 is one single question, which is how often would you say you have more than 6 standard drinks on a single day? And if the patient says, never, then the odds of that patient having a significant alcohol use disorder is basically nil. And so you can get if you just want to do a crude screener, then asking how many they have on a single drinking day is a single question that gets pretty close. And that has been well studied and validated.
In regards to the effect size, do you mean lasting change post brief intervention?
Yes. So most of these brief intervention studies have a follow-up, which is either 1 to 3 months after the intervention is done. In some cases, 12 months, but that's considered an extended follow-up. And in many studies, the brief intervention is assessed at a reasonably close time interval of 2 or 3 months. There is also evidence that repeat brief interventions leads to a sustained effect. So if the brief intervention was effective, it is quite reasonable to repeat it. And I might add that that's quite a natural clinical process of saying, yes, you've cut back, that's really good. I imagine you're feeling better in yourself, and perhaps if they had raised liver tests, your liver tests are better. And I encourage you to carry on. And if you see the patient again in 3 to 6 months for some other condition, you simply check on that again. So reminding people that this, it's not important for you to stop or reduce your drinking for 1 month in your whole life, but for the long term.
Yes, we've got another one. Are the indirect markers still less sensitive if the audit is now not as accurate due to change in guidelines?
So the guidelines are suggesting people drink, very small amounts of alcohol of about 10 standard drinks a week, 10 standard drinks a week or less. Consequently, at that low level of consumption, nearly all the biological markers are going to be completely normal. So the biological markers are going to be incredibly unlikely to detect that consumption with I might add, with a couple of exceptions, but for example, the gamma GT level will almost certainly be normal in a person drinking at that lowish level. The mean corpuscular volume, the liver tests generally, they'll all be useless for detecting consumption that's only a little in excess of that new guideline. So that's why we've recommended direct quantity frequency testing. At more moderate levels, at higher levels of excess consumption, in the sort of 4 to 6 standard drinks per day range, again, most of the biological markers are going to be not terribly informative, and that's why I direct questions either using the audit or using unstructured clinical history taking, will be more sensitive, will pick up excess consumption where most of these blood tests are not helpful. The exceptions to that are the new PEth and ETG tests. I haven't mentioned them in great detail because they're not widely available, but these tests are very sensitive and very specific. But you can't get them easily done, so not particularly relevant.
We've got any good modern research for youth in Australia and alcohol from a youth worker joining us from Tasmania?
There are a number of, most of the youth workers, when they're seeing patients, are seeing patients with really significant problems. In terms of support, there's something called the ERIC project, which looks at emotional regulation as a program of training staff in managing young people. So that is something new. That's being led by a group from Deakin University. I have a very peripheral association with it, so that's how come I know about it. So ERIC is something that's good modern research for youth in Australia. It's not specific to alcohol. I don't think there's any good modern interventional research that's specific for alcohol. Obviously, most young people with significant problems with alcohol, it's not specifically alcohol. They have either multiple substance use problems or a broad range of social challenges.
Last question that I have online here is, are you aware of any doctors supplying anti-abuse implants?
I've certainly heard of anti-abuse implants. I'm aware that some doctors have done so. They're not registered in this country, and I'm aware of past research into them, and the research led to the treatment being abandoned because they weren't able to generate long-term adequate levels of anti-abuse. I might add that even if they could do that, it's quite problematic in that people's motivation to stay off alcohol can be quite variable. And I would be concerned about people drinking whilst they're on it if they've changed their perspective on alcohol over a long period of time. I could see this being associated with some really quite bad adverse incidents. So I would not be keen to do it, because whilst anti-abuse has some benefit, the retention in anti-abuse treatment is quite low, and when people stop taking it and go back to drink, at least they go back reasonably safely to drink. It's a failed treatment, but at least it's a reasonably safe way to exit the treatment for those that want to exit treatment. It's very hard if the anti-abuse implant is, in your belly and effective, to exit treatment if that's what you wish to do.
Yeah, it looks like that's all I have. So, I want to say thanks, Paul, for joining us. Thanks, everybody online, for joining us. Our next webinar will be on the 1st of April with a presentation called Ibogaine, a Solution or False Promise, which is presented by Alla's own Dr. Nicola Ognjenovitz, and that'll be on the 1st of April.